or exposure may be working. And then the epidemiologic studies, which are our direct evidence in humans. And they will come in many varieties. And the two biggest ones that we'll talk about today are the observational studies, where we simply watch what people choose to do, and the intervention studies, the randomized clinical trials, where we try to make it as close to that basic research as we can by trying to control or intervene on the environment. Well, observational studies, is often said that there's a hierarchy to studies, and the randomized clinical trials are sort of the gold standard of the research. I would say that more in general, I think every study has a niche. And for every niche, every question that we're trying to answer, there is a study that is sort of not necessarily the very best you can do, but the appropriate one to start with. So when I think about observational studies, there's no question that they have advantages in terms of being simpler, being less expensive than doing a randomized trial. That's more of a logistics issue, not a science issue. When I want to go to the observational studies, it's when I'm looking at the big effects, which usually is not what I do. When the required duration of exposure is long, and it's a very important one. Trials are usually on the order of 3 to 5 years. And when something may take longer to show its effect on a chronic condition, observational studies really can give us information that other kind of designs may not be able to. Sometimes it's the only way to go, meaning that it's not feasible or ethical to do a trial. We'll talk about that in a second. It's always going to be useful. It's always going to be extremely useful for us to go the next step and to design a new trial. Because through our meta-analyses and through our systematic reviews, it is the way to look at these observational studies and get a sense of where we are in our knowledge as of right now. What order of magnitude effects are we talking about? And the most important thing is they work. There are a tremendous number of risk factors and preconditions to getting an outcome that we have learned through our observational studies, of course, starting with cigarette smoking, because we can't randomize continuous harmful. So when we look at it, we may say that we want to go to our next step to trials, but we must never underestimate how much observational studies do for us. But there are limitations of observational studies that are inherent, meaning it isn't that if you did a better study, trained better, learned under a master of doing observational studies, they would be different. This is inherent in the design. And in particular, it's because the exposure is self-selected. And anytime people select an exposure, they select more than that. There is a whole host of exposures or lifestyles that go along with eating a certain way, acting a certain way, getting a certain kind of drug. And so there is a risk of selection bias or differences in outcomes that are not due to the treatment itself, but to these other factors that are related to the exposure. And if we understood them well, we would actually be in better shape with respect to observational studies. But we know so little about so many diseases in terms of risk factors. So the adjustment may not be adequate for these confounders because we don't exactly know what the risk factors are, or in fact, if we don't know about them, we can't even measure them adequately to be able to do this. So really what observational studies can do is give us the best, albeit a little vague, answer to real-life questions, while we always know we're going to be saddled with concerns and residual doubts about confounding. So the randomized clinical trial, how does that complement observational studies? Well, yes, it's more costly. Yes, it's more logistically difficult. Yes, there's issues of ethics and feasibility that you won't see in an observational study. We know you can't randomize harm. We know that people have to be willing to be randomized in a study rather than just being followed. But if we can do them, if they are well designed and conducted, their niche is that because they are minimizing bias and confounding because of the way they are designed, the randomized, double-blind, placebo-controlled, attention to treat analysis, those aren't ivory tower words. They are all to minimize bias And because of that, they can accomplish in their design, if they're well designed and conducted, what the observational studies strive to do and have difficulty doing. They can detect statistically small to moderate effects, which is so important to us, but so hard to definitively evaluate because of their design. Now, so if we said that observational studies give us the best vague answer to real-life questions, trials will give us a precise answer by minimizing confounding to very specific questions which may not in fact reflect real life. So how do those go together? Well, it has been shown that in a majority of situations, or many situations, it can be found that the trials and the observational studies give us about the same order of magnitude. And there was an article in the New England Journal that documented that. There was commentary on afterwards that said we found little evidence that estimates of treatment effects are consistently larger or qualitatively different than those that we get in the trial. But the fact remains there are situations where, in fact, they are different. And it's when they are different that we learn so much about sharpening our skills into an analysis and absolutely sharpening our skills about designing better studies for the future. And so what do we do? What could it be when they're different? Well, it could be that something went wrong with the observational study. It could be that something went wrong design-wise with the trial. It could be that both of them were not designed well and they just came to different answers. Or it actually could be that both of them didn't answer the question that they were given to answer. They're answering different questions. So what have we learned from that that will allow us to do better in the future? So I want to use very quickly 4 examples that I've sort of lived through over this last period of time. Hormone therapy, risks and benefits from the Women's Health Initiative, aspirin and cardiovascular disease in men versus women in the Women's Health Study, beta-carotene and lung cancer, or nutrients for beta-carotene and lung cancer, and then vitamin E and cardiovascular disease. And I'm going to touch on these not so we go over the findings. You know these examples, but we go over what then the message was that needed to be looked at to figure out what happened. The Women's Health Initiative, we all know very well, observational study plus a trial, and part of the trial was to look at hormone replacement therapy on heart disease, osteoporosis, and breast cancer. Women who did not have a uterus were given conjugated estrogen plus progesterone versus placebo, as opposed to women who had had a hysterectomy. And the point was to look at whether the estrogen plus progestin decreased heart disease and osteoporosis-related fractures, increased risk of breast cancer, so that basically how did it come out on a balance of risks and benefits on overall health. Now remember where we started when we started the trial. The trial had to be in a context, a totality of evidence. And the totality of evidence was about as consistent on observational studies as we could see. That based on more than 40 observational studies, if you look at the summary relative risk, the summary relative risk was a 36% reduction in risk of coronary heart disease among women who had ever used hormone replacement therapy, and about a 50% reduction among those who were never users. And they were consistent whether you did population-based cohorts, cross-sectional, case-control studies. It didn't matter. We were seeing the same kind of finding. And many people felt that it was so consistent that it was actually unethical to give a woman placebo because she would be denied the benefits of hormones. But what swayed the thinking to allowing enough investigators to do this trial is confounding. That women who took hormones for an extended period of time were going to be different than women who didn't take hormones for other reasons that could in themselves affect the outcome under study. If they were doing this to prevent their risk or lower their risk of heart disease, They were probably leaner. They were probably not smoking as much. They were more physically active. They saw their doctors more regularly. They were more educated. They were doing everything that they could, and this was one of their weapons they were using to reduce risk of heart disease. And all these other factors could in themselves affect the risk of heart disease that we were looking at. So the only way